before we begin. This session is being recorded. Everything will be recorded up to the discussion period at the end. So every speaker will have time to present, and then after their presentation, there will also be a 10-minute question period. If you're comfortable, we do invite you to unmute your mic and ask your questions. But if you're not comfortable with that, that's totally okay. In that case, you can put your questions in the chat, or if you'd rather ask something anonymously, please direct your question to Ainsley Smith through direct messaging in the Zoom chat. I think that she will have a message pop up in the chat soon, just introducing herself. And just to let you know who she is. And we'd be happy to take any questions in any of those three ways. So without further ado, let's get started. It's my pleasure to welcome Dr. Tito Daodu as one of the panelists for our event. Dr. Daodu is a pediatric surgeon at Alberta Children's Hospital in Calgary. She was born in Nigeria and raised in Winnipeg, where she attended medical school at the University of Manitoba. She completed her residency and fellowship in Calgary and did a master's in public health at the Harvard T.H. Chan School of Public Health. Dr. Daodu has a passion for public health and promoting justice and equity in medicine. She is actively involved in public health research, focusing on improving surgical outcomes and making surgical care more equitable and accessible in Canada and around the world. So Dr. Daodu, we are so excited to hear from you and to learn from you today.
Thank you so much for the introduction and for giving me the opportunity. I'm going to share my screen. Hopefully this will all work out here. Great, can everybody see that? Awesome.
Yes.
Okay, so I'm Tito Dawudu, and I'll tell you a little bit about myself here as we go along. I am a pediatric surgeon, so I feel a little bit weird as a pediatric surgeon talking about mental health, because you might have lots of presuppositions about the field of surgery, and you might think that surgeons are not mental health professionals, and you would be correct. I am not. However, I do have the lived experience of being a Black woman in this country, going through the fields and professions of medicine. So hopefully what I share today will also have an impact. So it is Black History Month, and I found this, and it really actually spoke to how I'm feeling this year around Black History Month. I think last year I was really into like celebrating Black joy and all of the different ways in which we can celebrate, heritage and history. And just after the last year, and maybe just being a bit run down and just seeing things and working in the system and trying to get things done, I feel a lot of just rage, really. And I thought that was kind of appropriate for a talk about mental health, where this is like my #1 emotion that I've been feeling lately, and especially this month, because in our communities, in Black community, particularly, and in communities of color, there's a lot of sources of rage, disappointment, things that are really hard to face. And and when you're working in these fields and working in health equity, and you're seeing just the slow wheels of change, it can be really easy to lose the joy and just feel the rage. So how do we protect love, power, and become a part of the revolution? Tell you a little bit about myself. So, my full name, my real name is Oluwatomilayo. Tito is kind of a nickname that I got from my grandmother, and luckily is shorter and easier for people to get. I was born in Nigeria, and along the path of my life, I actually lived in Jamaica for a few years with my family. We lived in the UK also really briefly with my family. So we did a lot of traveling, a lot of moving around as being a first generation immigrant. Till finally we came to Canada, where my parents, my mom and my sister and I at the time settled in this place called Winnipeg, which you might have heard of. And they chose it because they thought, being the geographic center of the country, it might be where all the action is happening And I think that they were probably right, actually, about that with Winnipeg. Probably part of that globe hopping as a kid made me really interested in seeing the world, seeing what was going on there. But the other thing that happened is that I got to grow up in different settings. I got to grow up where I was in the majority of what people looked like. I got to grow up where we had a lot of money. And then I also grew up when we had absolutely no money and my mom was working 3 part-time jobs, going to school, trying to take care of my sister and I. And that really sparked in me an interest for public health and equity, even at a really young age, where I could see that there were these massive disparities in the way people were treated, people had access. And so that kind of took me on the journey of medicine that I'm on now. I started on the far edge of the country in Nova Scotia at St. Francis Xavier University. And then I went back home to Manitoba at the University of Manitoba, where I did medical school. I've been in Calgary, like we've said, for a number of years now, where I did my residency and fellowship. I did an online degree at UBC, a graduate studies in international surgery, and that was a big part of my thinking about public health and global surgery and how to start to incorporate these things with my interest in surgery. I always thought I wanted to do public health, and then I fell in love with cutting people open, and how do I start to fit and reconcile those things? And then I finally finished school, this past year at the Harvard T.H. Chan School of Public Health, where I did a master's in public health. And actually, throughout this entire journey, what that led me to become is the first Black woman to be a pediatric surgeon in Canada. And that happened in 2020, which is actually a little bit ludicrous to me. Somebody told me that when I was in my fellowship. I met somebody at a conference. They said, oh, there's never been a Black woman who's been a pediatric surgeon in Canada. I don't know why that was shocking to me, but it was. And I thought, well, it's 2020. Seems insane that it's taken so long for somebody like myself to be able to do something like this. And people talk about it a lot. I'm happy that I'm there, but it also tells us that there's a lot of disparities and there's a long way for us to go. I would love to be in a world where my children are not the first Black of anything, that it's just normal for them to seek careers and live freely and equitably in our society and our health systems. So we know this, or maybe we don't know this, but race is a social construct. We've made it up. Not the people in this room, but this is something that was made up, to put us into boxes and to decide which boxes were good and which boxes were bad. And that social construct is something that we follow and we keep to this day. And the anti-Black racism, apart from racism in general, is its own thing. It's really unique. It's really different. And in Canada, that's really rooted in an experience of enslavement, and it's targeted against Black people. And I'll talk about a number of reasons we don't like talking about that in Canada. There's disparities in medical conditions and risk factors that are not explained by biologic differences between races. Like I said already, race is a social construct. But a lot of our literature, if I look at it and when I'm reading it and it's making me upset, talks about and tells us things that Black race is a risk factor for XYZ, where we know it's probably not race, it's not your biologic difference, but the society and the social construct or the racism that has actually contributed to these disparities, these increased risks, these increased social factors. And we can't deny the existence of systemic anti-Black racism in Canada, although our medical systems have tried to deny it for a really long time. And we can't deny how it affects the health of Black Canadians and also all Canadians by that virtue. And so what we should do is confront and interrupt anti-Black racism in medicine. But this takes action. It doesn't take just listening. It takes us actually doing active work to be able to confront these things. This comes from Dr. Amy Tan, who is a really exceptional researcher and an advocate. And it's just to show you what racism really is, because we think about it often as just the stuff that's at the top of this iceberg, the things that you can see. We're pretty good at calling out somebody using the N-word or somebody committing a hate crime, although sometimes that's not so easy for us to call out. Things like blackface, somebody raising a Nazi flag, we can say, oh yeah, that's racism, that's white supremacy, that's bad. And these are things that we think about as being socially unacceptable. But under the surface, there's a lot of really socially acceptable forms of racism that are deeply embedded into our society. And these are things that we don't necessarily see or pay attention to as often. And all of these pieces really take a toll on the health of all of our citizens, and particularly our racialized citizens and Black patients. So we don't talk a lot about the housing discrimination and racial profiling that happens here in Canada. We don't talk a lot about hiring discrimination practices, victim blaming, or Eurocentric workplaces. We don't talk about, ideas like color blindness and how that really doesn't really work out for what we're really talking about. The myth of meritocracy that doesn't apply when you are not given the opportunity to gain merit. And so these systems of racism that are below the surface and they're acceptable, we just say that that's okay because they're there and it's easy for us to ignore. Those are really contributing to these health outcomes that we see in ways that, yes, overt racism does, but these deeply societally ingrained systemic forms of racism are so hard to take and attack, and also to prove to people, even though we know that they're there and they are actually contributing. So I'm a health systems researcher, and so I always talk about how every system is perfectly designed to get the results it gets. So if we're talking about there being problems with outcomes for Black Canadians, it's because our system is not designed to make better outcomes for Black Canadians. And that's just the reality. Our system gets the results it gets because that's the way that we designed it. And when you're looking at health systems research from a really broad perspective, that's a really important sort of point to understand. So let's just take a look at what this means in our systems and what they look like now. If we take a look at what medical students look like across demographics, this is a study from 2020. And essentially, we found that respondents here, and this is an American study, but a similar study was done in, actually, no, this is a Canadian study, found that we were less likely compared to the Canadian consensus population to identify as Black. So significantly less medical students are Black compared to what the broader population is, or Aboriginal. And so this is a problem that is clearly ingrained into the way that we even admit students into fields like medicine to begin with. So how do we get a problem of me being the first Black woman to be a pediatric surgeon? It starts with the fact that Black students are not admitted into medicine as frequently as they should be, even just by playing population odds. Someone did a study of pediatric surgeons across North America, and they reviewed 4 decades of graduating fellows and leadership in pediatric surgery. And surprise, surprise, as it turns out, there are 4 total Black women in pediatric surgery, now 5. A friend of mine just graduated last year in North America. So this is kind of crazy as well. They looked across the leadership and they were able to find 2% of all presidents or executive leaders of the American Pediatric Surgery Association being Black. And that was all inhabited by one individual who is the current president of APSA. In my own specialty, so looking at the intersectionality of gender and visible minority status in general surgery residents, this is a study from the Canadian Association of General Surgery Resident Group. They found that female sex and visible minority status was associated with a lot of adverse implications for training experience, including feelings like being not included, having less mentorship than other residents, higher rates of burnout and a desire to quit residency, and also being questioned on expertise at a higher rate than non-Black or non-visible minority and non-female residents. And so being in a field like surgery, where we've known for a long time, it's quite a male-dominated field, but that intersectionality of gender and visible minority status has even higher repercussions. And for myself, you know, the number of times that I thought of quitting general surgery residency because of some of these things that I didn't recognize were related to those feelings of mistreatment, I just thought maybe I wasn't good enough at it. That happens repeatedly. And when I read this study, it was one of those moments when I went, oh, maybe that thought that everybody wants to quit general surgery at least one time a year is not the case when so many other residents going through the same program report very different outcomes and very different feelings across the time they spend in residency. And I'm a pediatric surgeon, so I just felt like from a public health point of view, we should also talk about what happens to children when they come into our hospital. And there was a study that came out, there was a landmark study in 2020 that found that after surgery, Black children were more likely to die than white children. And these are otherwise totally healthy kids. So this study was done in 2013, which found that the outcomes were worse for Black children, and 2004. So we're seeing here, the trend is that over 20 years or more, and probably even beyond that, that Black children coming into our hospitals because of systemic racism, unconscious bias, are having worse outcomes compared to other children. And so this is serious. It means that it's really affecting us. We talk about this a lot when it comes to COVID-19. We talk about, we've seen that happen where the outcomes for Black patients are worse in COVID-19 compared to the general population. And that's not because there's something biologically different about Black people. It's because, again, our systems have led to these barriers and created these disparities. So we get disparities in healthcare outcomes, in access to care. We have biases in the way research is conducted, including who are participants in research. Mental health diagnosis and care is also a major issue amongst Black populations. And these are the disparities that we live with all the time. And so when we look at the research that has gone on, there's increasing research that shows that anti-Black racism takes a toll on the mental health, despite the resilience of Black Canadians, and that Black Canadians can't as easily access culturally appropriate mental health supports and services. And just racism itself is a risk factor for mental health issues. Anti-Black racism is insidious. It's particularly insidious here because we think it doesn't happen to us, but we know that prolonged experiences of racism permeate into individual well-being, and they can lead to many detrimental effects. And witnessing or being a target of anti-Black racism during your whole lifespan actually has adverse events on both your mental health and physical well-being. And so some of these things that we see are not just rooted in mental health, but we know that mental health and physical health they're not separate entities. They are related to one another. Your mental health affects your physical health and vice versa. These affect the ways that you show up in the hospital. And so these are problems that are really deeply, deeply ingrained. And that means that the experiences of Black people in this country are very, very different fundamentally in so many ways than those experiences of those white Canadians. And just wanted to say that the minority tax is taxing, because for those of us that are working on, I don't know what this picture is. It's like, I tried to find something on minority tax. I think this is actually a tax service. But there is a minority tax, which means that in those that are trying to look at and address or solve these problems, they draw on this group of minority folks that they think can help it. But in reality, the job of solving racial inequities and pushing things forward should not be the job of those people who have experienced, faced, and been subject to terrible racial inequities. Because number one, there's so few of us overall in the system that are here to fight the good fight. Number two is that, sometimes I think this is great. I want to be involved. I want to be engaged, but this is not my job. like when you're sitting in a position of power and privilege, should be your job to try to bring people up and create equity, and not all overly relying on those people who have experienced huge inequities. So we see that there's this underrepresentation in medical and surgical training, in our leadership, in mentorship that people get. And those disparities are permeating. And from a training point of view and from a career point of view, it's really, really tasking. The problem in Canada is that we do not measure any of these things. So until very recently, you couldn't just get a set of data from Stats Canada or Canadian Institutes of Health Research or any of those things that you could specifically look at, okay, well, what is the impact on this on Black Canadians or Indigenous Canadians? Because a lot of this data just was never captured in our health records, in our census data, in many of those things. So we have no good way of knowing what the direct impact is. And that actually makes it so much easier for us in Canada to ignore what the problems here are. We know that Black people comprise at minimum 6.5% of Canada's population. Some will say up to 6.5%. About half of these Black people in Canada are born in Canada. There's also a large immigrant community. Slavery was abolished in what was to become Canada in 1831. So it was about 27 years before it was abolished in the United States. But still, there was the Black people, and I put this picture of the $10 bill because I had my little niece come over to my house this weekend. She said, "Oh, we are learning about Viola Desmond in our Black History Month class." I said, "Oh, that's really cool. Yeah." She's like, "Yeah, she's on the $10 bill." And she said, "But there's these other bills out there, these weird bills that they have some other person on them." I said, "Yeah, she's not been on our bills for a long time. She's only been on our $10 bill for a few years." And she was shocked. She's 8 years old. She was shocked. She was like, "Whoa, what do you mean? How come she hasn't always been on our bills?" And so we had this conversation, me and my 8-year-old niece, about what that means. Like, how do we get to this point where we are now in history, where we come from and where do we need to go? And that's a tough conversation to have with an 8-year-old, but she really felt this disappointment, I think, that this is the first time that a Black woman has been on a bill, and like it just happened now, like just since I was born. Even she gets that those things are not fair. Slavery is a foundational institution and building of this nation, as it was in the States, despite us abolishing it earlier. And Black Canadians also continued, even after slavery was abolished, to experience inequity, poor treatment. And this is a great example of what that is and what Viola Desmond stands for. This is our problem. It's a Canadian problem. We love to look south of the border and say that it's them. But Black Canadians have been raising awareness about anti-Black racism for centuries. If you go back to Nova Scotia and looking at the populations there, their treatment, being put into ghettos, those are things that they've been raising for centuries. This is something that has even been brought up to the United Nations, which in 2017 found that the structural racism that lies in the core of many Canadian institutions and the systemic anti-Black racism that continues to have a negative impact on human rights situation of African Canadians. Like, this is the UN putting together a task force saying that Canada's anti-Black racism problem is a real issue. And we're seeing that in higher rates of poverty, lower education, overrepresentation in the criminal justice system. Black Canadians earn 75 cents on the dollar compared to what white Canadians earn. And that is when you account for education, socioeconomic status, and many other factors. Like, this is the case. We also know that if you just look at one city in Montreal, 13.5% of Black people with a graduate degree are unemployed, which is comparable to the rate in that same city of non-Black people who had completed a high school degree. And so it's a Canadian problem as much as it's anybody else's problem. I'll talk a little bit about mental health here, because racism is really stressful, takes a toll, and it makes us sick. There's lots of studies that describe how racism and the impacts of discrimination and persistent discrimination actually changes your biology. So not just in causing mental health issues, but your actual biology changes. There's different types of cell types in DNA that are like physically changed by repeated discrimination and stress. Not only that, but racism drives upstream societal factors that continue to perpetuate inequities in health. And this is both in mental and physical health conditions. So we've talked about this again. Every system is perfectly designed to get the results it gets. And what our system is getting right now is a system where Black Canadians are disproportionately affected by poor mental health and physical health outcomes. So we have to change the system to change the result. How do we change the system? You know, in some ways it's just about education, things like this, getting to learn things and being open to learning. For instance, I learned recently, just in the past year, that pulse oximeters have been designed. These are things I use in the emergency department to tell how good somebody's oxygen saturation is. But we've known for 30 years that they actually don't work well for Black people, and that they overestimate how high your oxygen is by about 8 to 12%, which is major when you're thinking about sending people home because you think they're fine because their pulse oximeter says that their oxygen is high. And then you discover actually there's a good chance that this is 8 or 12% off. And so you would never send somebody home in those conditions. And so that contributes to why a lot of Black people are not believed when they go into the emergency department and they're feeling breathless. And it's probably contributed to why many people, many more Black people have died of COVID-19 because they looked okay. And those kind of things happen all the time. We need to change our individual and organizational behaviors. And that involves thinking about what we do, our own biases, how we act and how we work every single day. And thinking about becoming allies where you are removing the stress and the strain from other people and giving room for voices that need to be heard. Committing to diversity in leadership and not unseeing the things that you see that are stressful or painful or feel off. So not everything that is faced can be changed, but nothing can be changed until it's faced. And so that goes to the don't unsee it. I'm going to end the show and stop there because we have the opportunity to not unsee these things and try to face them. So that's it for me.
Thank you so much, Dr. Dawudu. That was an amazing presentation. We are now going to be opening up the floor to questions. So if anybody has questions, once again, feel free to unmute yourself and speak your question, or you can put it in the chat, or you can directly message Ainsley for an anonymous question. And it looks like we actually do have an anonymous question right now. So this individual is asking, what constitutes culturally appropriative mental health care?
Yeah, so that's a great question. And I went through this process. It was really, really challenging because, you know, I really believe in mental health. Like I'm going to say that out loud. Like I have throughout my training, I would mental health.
Here is my agenda. I will talk about my research program, Black Experience, and then Black Youth, mental health of Black youth. And sorry, it's, I've had a few, talk back to back today, so hopefully I can keep my energy up. I respectfully acknowledge that I'm located in Treaty 6 territory, and many of you, I believe, are located in another territory. A traditional gathering place of diverse Indigenous people, including Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Sault-Sioux, Anishinaabe, Inuit, and many others, whose histories Languages and culture continue to influence our vibrant community. Many of us have come here as settlers, immigrants, newcomers in the generation or in past generations. I would also like to acknowledge those of us who have came here possibly partly as a result of transatlantic trade. Therefore, I also honor and pay tribute to the ancestors of African origin and descent. So my research program seeks to address immigration and health policies and practices. I've been involved in around 80 funded research projects in the area of immigrant health. I am lead on 30 of those research projects, and around 15 of those research projects that I'm lead on are on Black population. So around half of my research, but I don't only do research on Black population. And I've been engaged with collaborators in 30 different countries. So some of the strategic directions of my research program is to drive high impact policy and practice research. I am continually engaged with policymakers in terms of how to ensure research is responsive to policy, how to mentor and train diverse, talented researchers, to build cross-sectoral networks to improve immigrant health, and to shape Canadian international policy and practice on immigrant health. So some of the past findings of my research program includes Black people experience racism at work. So this person was from Africa and he was hired as a certain department. He was supposed to work the same job as others, regardless of the color of his skin, but they give him a cleaning duty because of the color of his skin. And that was from an immigrant service provider that was non-Black. Black children experience racism in the school system. This was from a African parent and also a community leader. And people talk about like racism within the school system, like our kids are really being looked at different as soon as they walk in. So if the Somali kid does the same thing as the white kid, they're going to be looked at different. That anti-Black racism contribute to health of Black youths. And one youth said, oh, I grew up with so much internalized racism. God, I hated myself. I wanted to be white so bad. I wanted to have straight hair. I wanted to have lighter lips, skin. And this same youth in the same interview talked about how she was crossing the street and someone threw a Slurpee at her and called her the N-word while crossing the street. And she continues to internalize this racism that she's experienced. That non-Black professionals are often unable to provide anti-racist care. So one said, when you call out link, so they're asking you if your child is blue, and being a Black person, my child never turns blue. So then it makes you wonder how well these professionals have been trained to know more about other races. And it's the same. Some weeks ago, I actually called out link, and they asked me about, if someone in my house is blue, and I'm like, I think I just sort of told you that I'm Black. And then, one talked about, you tell a professional, a mental health professional, I'm experiencing racism. They'll be like, what? No, oh, what? Are you sure? And then they will just try and, let's get you some other strategies. So they'll just try to bypass it and move to something else because they don't feel comfortable dealing with it. And I believe Dr. Tito already mentioned this issue. So Black people in Canada, we have close to 1.2 million people in Canada reported being Black, and that's 3.5% of the population. But we must also say that there's a difference between the percentage of Black people in Canada and the percentage of Black people in Alberta. So we have a higher percentage of Black people in Alberta, especially in the cities of Edmonton and Calgary, than the rest of Canada. I don't know if it's like 5% or 6%. Alberta population grew fivefold. A Black population grew fivefold between 1995 and 2016. And within this time, we had the fastest growing population of Black of any other province. As of 2016, there was 129,000 Black people in Alberta. But please note that that was as of 2016, which is 6 years now ago. So our population has grown even much more bigger. The proportion of Black women with post-secondary education has increased over time, but they continue to face poor employment outcomes. That's very, very important to note. So for example, there's diverse differences in Black population in educational outcomes of Black population. And when we talk about Black population, oftentimes we would think about Black people as a community. No, we're a bunch, we're communities. There are several communities located, and there are several differences among Black population. So we see in terms of, Black women, for example, from Nigeria and Cameroon, have one of the highest post-secondary completion rates in Canada, but also one of the poorest employment rates. Black men have experienced a decline in post-secondary educational completion rate. And one of the things is, over time, we think, our country is getting better and we're becoming less and less racist. But what is happening over time is the income inequality between Black men and the rest of the population is continuing to grow. So while, everyone's income is on the rise because of inflation, everything gets more expensive, people's income is on the rise. For Black men, it's not been the same. It's remained steady and not risen. Black men and women often experience racism in the labor force. And in healthcare, we have what we call Cappuccino Effect, what I call, and I wasn't the one that coined this term. And it's, when you look at the healthcare workforce, it's white on top, or mainly white on top. And when you look underneath, those that work in the lower ranks, it's oftentimes Black people. And 1/3 of Black women work in healthcare and social assistance, and many of those people are concentrated in the lower ranks. We have, 3.5% of the overall Canadian population are Black, and while it's 2.3% of physicians. And when we look at physicians and where they are there, many of those in the, that are like in the executive positions of healthcare institutions, it's, we don't have too many Black people and physicians that are, top executive managers, for example, of places like AHS and places like that. So in terms of Black youths, they experience poorer educational outcomes than other youths. This is despite the higher educational aspirations and resilience of Black youths compared to other similarly aged racial or ethnic groups. Negative attitudes of teachers towards Black youth, lack of African Canadian history and culture in the educational curriculum, systemic racism, low teacher expectation, alienation, and lack of Black teachers and mentors all contribute to educational outcomes. Lack of credential recognition of Black parents also has an influence of Black youth. Black youths and Filipino youths are the only group in Canada who do not surpass their parents' level of education. So what we currently have is oftentimes, on average, Black parents tend to actually have higher education than their children, which is a sad news that we have in Canada and must change. And of course, one of those things is, when you're growing up, you see, oh, my parent has a lot of education, and you see, oh, they're not using it for much. Then you're not, that doesn't motivate you to aim high because of what you're seeing in the society. Oh, I don't know why this is here, but I'll talk about it. Experience of Black faculty members. So Black faculty members, I'm not sure if I meant to put this here or not. They experience inequities in pay. And this is not just Black faculty members, just general population. People experience microaggression at work, unconscious bias, who is considered a good colleague, either as faculty members or even at work. Really, there's unconscious bias tied to that. Racism and power struggle, inclusion, exclusionary practices at work. Black people also, we tend to do a lot of mentoring and service responsibility without enough compensation or acknowledgement of some of those invisible work that we do. And also, the type of work that Black people, faculty members tend to do tends to be in equity-focused disciplines. So anti-Black racism are policies and practices rooted in Canadian institutions, such as education, healthcare, and justice that mirror and reinforce belief attitudes, prejudice, stereotyping, or discrimination towards people of African descent. So Canada, I think Canada has a history of anti-Black racism. So we do have a law that was the Immigration Act of 1910. There was a law that actually barred people based on the color of their skin of being able to come to Canada. One of my colleagues talks about that Canada, we've had polite racism. And it's to say, oh, I'm trying to protect you from the climate here. So please, we are not going to allow you to come here because your race cannot survive in Canada. And there was actually another policy that they tried to implement that, or maybe they did implement, that barred the Negro race, that said the Negro race is deemed unsuitable to the climate and requirement of Canada. And this was to prevent especially Black people that were migrating from the US to be able to come to Canada. So we do have a history of racism. I think Dr. Tito mentioned this, probably another part of this document, but in 2017, the Prime Minister of Canada had some people come to Canada to come and look at, from the United Nations, to look at the experience of Black populations in Canada. And the document concluded that Canada's history of enslavement, racial segregation, and marginalization of African Canadians has left a legacy of anti-Black racism and has had deleterious impact on people of African descent, which must be addressed in partnership with the affected communities. So, and this, of course, kickstarts. So oftentimes people think, everything started with George Floyd's murder. There was a lot of things already happening in Canada. We're trying to deal with this huge issue about anti-Black racism that we continue to experience. So anti-Black racism in health, we know that anti-Black racism results in discriminations towards Black people and reinforces systems of inequities in how resources, power, and opportunities are distributed. It exists in overt daily indignities, but also including microaggression, and also in subtle and pervasive arrangements, such as through undertreatment in hospital. Perceived discrimination in accessing health services contributes to distrust of healthcare professionals, leading to delayed in screening, infrequent checkups, alteration in health status, such as diabetes. And anti-Black racism is deeply systemic issue, and at the intersection of health contributes to higher prevalence of chronic health conditions such as high blood pressure, diabetes, cancer. We have a high rate of HIV and mental health problems. So I don't know how many minutes I have, but if I have enough minutes, I will talk about a youth-led participatory research that I did on Black youth. So, we sought to look at the mental health needs of African, Black, and Caribbean youths, and to look at the barriers to access to mental health services for Black youths, and also the potential that exists to mobilize Black youths towards action. We interviewed 30 Black youths, and we had conversation cafes with 99 youths. These were some of the youths that led this project. So the youths, they told me that they wanted to collect their data themselves. So they ended up actually collecting the data themselves. Someone wrote a comment. They ended up collecting the data themselves, and they ended up collecting the data themselves, and they also did a presentation of their findings. So some of the factors that contributes to mental health of Black youths, the most frequently talked about factor was racism and discrimination. And I already talked about the first statement with about anti-Black racism. There's also the intersection about racism and masculinity, especially for Black males. So, one of the Black males said, in my community, it's easy because obviously the community understand your struggles that are out there. Outside my community, I think I have unconsciously learned to do this. I'm thinking of the word, to start out with the notion that I'm not going to rob you, right? Kind of that I interact, especially just blatantly white, blank with white. especially interact with white people, just kind of the first thing I have to attack is the preconceived notion that I am Black, I am a thug, or I'm whatever. So imagine you're a Black youth and all you always have to be is on, you always feel like you have to always defend yourself or to always make people perceive you, change people's perception of you that, you're out there in a negative way, to do something negative. And one of the Black youths also said, Black male youths, because that toxic masculinity is not a Black thing, it's an everybody thing, it's every male thing. What separates us is we have an added thing called racism. Now, in terms of mental health, we are not talking as men. We are not taking care of ourselves mentally. And now there's this added factor of aid from another group of males who more or less have the same struggle as you. So in terms of cultural expectations, there are some people that consider mental health problems like a Caucasian thing. Like they're like, oh, like it's only that like white people that have this sort of problem. So there's this perception that, you're supposed to be a female, a strong Black woman, and then you're not supposed to have a mental health challenge. People also talked about the academic expectations and also about openness about mental health and the impact of openness about mental health and sense of community. And in another study, I looked at mental health of immigrant versus non-immigrant. And what I found was a major contributor to mental health was sense of community. When people felt like they belong to a community, they're more likely to rate their mental health as better. Also, spirituality has an influence on mental health. Some of the barriers that youths face in accessing mental health services include costs. So of course, if you have to pay $200 per hour for a psychologist, you may not have that. Geographical barriers, or just feeling like all the mental health services are located in areas that are predominantly for white people or located in white spaces. Lack of Black demographic representation. So feeling like, the mental health therapist doesn't fully understand your experience as a Black person. Lack of knowledge on mental health services. Intergenerational gap. Stigma and judgmentalism, and also the culture of independence. Some self-help strategies that were used by the youth include peer support, the use of religious teachings and practices, music, and sometimes negative practices such as self-imposed isolation. So, this begs the need in terms of addressing intersecting social locations, including social determinants of health, including gender, income, racism, and also awareness of unconscious bias and taking strategies to tackle those unconscious bias. Challenging anti-Black racism is important, especially also attending to accountability metrics. So one of those is, how diverse is your workforce? And what is the satisfaction rate of Black people attending or receiving services from you? Social conditions and determinants have implications for Black health. That Black people have several strengths that they can capitalize on, but also recognizing the limits of resilience. That the need to increase the representation of Black people within healthcare and strengthening communities, inclusiveness, and fostering belonging, and also building capacities. That's it with my presentation.
Thank you so much, Dr. Salami, for that amazing presentation. Yes, it was so lovely. And now we are going to move on to a quick question period. So once again, we're going to pause the recording and going to move on to our final speaker. So I am delighted to be introducing Kome Odoko. She received her Bachelor of Science in Nursing from the University of Alberta and completed her Master of Nursing at the University of Calgary. With a background in pediatric and adolescent psychiatry, Kome actively works with students, faculty, and staff within the UCalgary community to increase levels of flourishing and resiliency. She is also passionate about establishing higher education spaces that are equitable and inclusive to ensure that those who join our community feel valued for their skills, abilities, and contributions. Kome, we are so excited to have you here, and we're excited to hear from you and learn from you today.
Thanks, Danny, and also my appreciation to Dr. Daodu and Salami for setting such a solid foundation for me to build and end tonight on. I'm just going to go ahead and share my screen here, and hopefully everybody can see that. And so just based on the fact that we have shared quite a significant amount of information tonight, I'm just going to talk fairly briefly and probably from my experience as well, just to allow folks to have time to ask their questions and to be able to learn from each other in a really good way. So my role here at the university is to manage our student at risk program, which is an early reporting capacity for folks to seek help and support for students in our community. And so a lot of that work kind of helps me bring together my nursing background, my interest in sort of risk management, but also allowing for us to have conversations around how EDI, equity, diversity, inclusion, sort of impact the mental health work that we do here on the University of Calgary campus. And so this is an infographic created by our provost office for equity, diversity, and inclusion. And to be honest, when I saw this infographic, I was a little bit surprised. It really provides an insight into racial diversity and indigeneity at Canadian universities. And so we can see that Black folks, so Black identifying folks, make up about 3.5% of the general population at Canadian universities, which to me was a bit of a surprise. I feel like I lived a lot of my undergrad and graduate lives in really Black spaces. And so to see that number and to kind of, I guess, tie that to the lack of representation that we do see was really impactful as I prepared for this session today. But I also like to acknowledge the fact that, you know, we are talking about the lack of representation in our settings and looking at the fact that, you know, 0.8% of our senior university leaders are Black and 1.9% of full-time faculty are Black. And looking at the fact that even when you're looking at undergrad rates and graduate rates, that means that my experience of never having a Black professor in my undergraduate program is probably being replicated for a number of students while they complete their studies here and at other university or post-secondary opportunities across the country as well. And just adding the fact that Stats Canada also has similar numbers in terms of the breakdown of equity and racial diversity in our spaces. And I think a lot of that definitely contributes to the concerns that we see and how we sort of support students through those as well. I think this has been mentioned many times over, but, you know, Blackness and our experiences exist within power, identity, and privilege bubbles, right? And so knowing that Blackness in itself is not a monolith. We have varying differences, varying experiences. Even the definition of Blackness, I think, is something that the Black community is still trying to define for ourselves. And so recognizing that all of these play into different ways, especially with our mental health, right? And so we're talking about things like access. We're talking about financial impacts of folks who are able to seek supports, where you seek supports, who you talk to about that, how you get asked questions, how you answer those questions. And I think all of those factors really lead to really significant outcomes when it comes to, you know, Black mental health or the mental health of Black folks on our campuses. And so recognizing that we do all have diverse stories, I think something that is quite impactful in the work that I do, working to be, you know, driven by data and being a practitioner in that way. I think our lack of data on Black mental health has significant impact on the work that we do and how that work informs the sort of outcomes and interventions that we seek. So looking at our NCHA data, which is the National College for Health Assessment, and that was a survey that we typically were completing every 3 years. The last one was completed in 2019. I know that we are moving to a more inclusive and sort of more wholesome survey for the spring of this year. That is typically how we gather information on student well-being and the kind of concerns that we're seeing in our community. And in the 2019 survey, there were only actually 54 Black people or Black identifying folks who filled it out. And so a lot of that means that that data isn't statistically significant, but it also provides an opportunity to say, okay, how do we bring our Black community folks into these spaces to answer these questions? And so many of the concerns that I will be talking about today are mainly anecdotal in the kind of work that we've been doing here as a team at Wellness Services, and looking at things like anxiety and depression and suicidality and social anxiety and those sorts of pieces. All of those are common concerns that we see and support students with. But I think a lot of that has changed in the last 2 years, especially with a lot of the social justice moves that we saw in 2020 and 2021. We were having students who were actively, posting online and engaging in their communities about, racism and the impacts of some of these social justice movements that we were seeing online, but then also having to go to work and go to school and process some of those re-traumatization experiences by watching people, die at the hands of law enforcement and those sorts of conversations. And I really like this quote by Angela Barrett. It says that in good times, racism is a stressor, and in bad times, racism is a trauma. And I think that's something that people are always continually dealing with and processing, especially as Black folk too, in the sort of times that we live in as well. I also think it's important to acknowledge the fact that high functioning mental illness also exists within our really competitive academic environments. And so the idea that if you're able to get all of your work done and submit your papers and do your research, then you can't be ill or your mental health isn't impacted. I think a lot of that is tied to our definition of what excellence is and who is an excellent student, as has been previously mentioned as well. Knowing that even in the populations that we serve, there is a lot of racially based misdiagnosis, knowing that Black girls are typically underdiagnosed with ADHD because a lot of their symptoms are mischaracterized due to factors like who is assessing them in the schools, lack of access to care, mental health literacy with their parents. A lot of them are just described as being high achieving. And so then you spend your university years being high achieving, and then you feel burnt out at the end of it. And so being able to really put words to some of those experiences, I think, is really, really important. And just noting the obstacles too that we are actively trying to address that may block access for those who really need to be supported. And so a lot of it really is stigma, as has been mentioned also, and that's self, but also community too. I think Dr. Salami mentioned there is this perception that mental health is a white thing, it's not a Black thing. We don't really have that, but I think if you gave language to the experience, I think people would find that they probably experience a lot more mental health challenges than they would had previously identified. I think things like assessment considerations regarding things like suicidality. So research has shown that depending on how you ask questions, certain racial minorities actually are less likely to answer truthfully based on how you ask those questions. And there are differences in terms of completion rates and attempts depending on racial identification as well. Obviously, we acknowledge the history of the Black community and the medical community as well. And I think a lot of that has a history of fear and mistrust. And Dr. Salami had also mentioned confidentiality. Knowing someone that might know someone else that makes you more likely or less likely to actually engage services as well. I think varying rates of mental health literacy, as I mentioned, being able to give words or essentially offer information and be clarity really on what you're experiencing. So if a doctor says, okay, what does your anxiety feel like? I think there are a lot of folks, Black and otherwise, that don't really have the words to describe that experience in a way that might make sense to a practitioner. And so being able to really look at what that means and how we build tools that can actually effectively assess across these sort of racial lines. And so this is an infographic that was released as part of Statistics Canada's Black History Month platform. And to be honest, it kind of hit a little bit differently for me. So it says that in 2016, according to statistics, 1/3 of female Black workers aged 25 to 59 in Canada worked in the healthcare or social assistance sector, and that no other sector had such high proportions of Black female workers. And I think for me, that experience of reading that just said, it brought back feelings of just being undervalued and being underpaid. Because if we're looking at folks who are, executives or are visible leaders in these sectors, they typically don't look like me, right? And so a lot of that brought forward for me my experience of being in ER with my mom and being anxious that she wasn't going to get treated because they may not, her accent might be something that, they disregard, they might disregard her pain, and that I needed to be there to be able to advocate for her despite being a mental health professional myself. It brought back feelings of being in class and knowing that I would never see anybody like me, and being in a cohort of 200 nursing students and only having 10 people that had a similar lived experience to my own. It brought back experience of just being able to navigate supports with Black students to say, okay, like, I understand this is what you're feeling, this is where you're going, how do we sort of help you do that? A lot of the glass ceiling, rhetoric that we sometimes hear, it shows up a lot for Black women, especially looking at how we move up in sort of corporate spaces that sometimes tokenize us for sort of a checkbox. And so reading this just felt a little uncomfortable, honestly. I feel like the idea of celebrating, Blackness and saying that these women are working in these areas and that, were kind of on the front lines, I feel like probably did the opposite of what they were hoping to achieve. And I think it also kind of ties into how we bring folks into areas like medicine or law. And I know that our Black Students Associations and those two faculties are doing a great job of increasing applications, but also acceptances in those places as well. But it's knowing that this may be where we're at, and that needs to change, really. And that this narrative that, we're like Black women are just supporters and naturally giving is actually quite problematic and needs to be addressed in pretty significant ways, I would say. And so just in talking about capacity for growth, I think this was mentioned a little bit earlier, but looking at culturally competent approaches to mental health services. And I think a lot of that really is determining correct fit. So someone can ask a question about, is it okay for me to ask my patient if they would like a Black provider? I think we look at the context of that, right? So have they verbalized that? Is there uncomfortableness with folks who maybe have been providing prior care? We really need to try and not make assumptions or to be able, or try to interpret other people's experiences while they are in our healthcare system. And so I think a lot of it really is figuring out what is patient best, or looking at patient-centered care with this sort of approach or with this sort of lens. I think it's increasing representation in healthcare practitioners, as it has been mentioned, and also in visible leadership positions as well. I think we do maybe not the greatest job of highlighting people that are doing really great things. So I have a friend, Antonia, who is working and is an MSc candidate at the McCraig Center and doing really amazing work there. I have folks a friend Femi also, who is working with CASA right now to look at how we talk about gender-based violence in our Black communities and how the outcomes of that actually show up in our mental health care, in our physical health care, all of those sorts of things. And so being able to actually talk about those things, I think, in bigger settings and put those folks kind of at the forefront of the work that we're doing, I think is really, really important. I also think addressing mental health literacy through innovative practices is really important. And so I really like to listen to rain when I go to bed. Like, I like thunderstorms and things like that. And typically when I start to look for videos on YouTube, there's always this one ad that pops up through Calm. And the video ad starts off and it says, "Hi, my name is Chike." And every time I hear that, I feel really, really good. And I think the reason that I feel really good is because I'm hearing a Nigerian man with a Nigerian name talking about rest and calm. And that makes me feel like I fit in that sort of, in that area. And I can acknowledge that, and I can really relate to that. And so I think there are different ways that we can really talk about mental health when it comes to Black well-being, and in really, really cool ways. I know there are a bunch of startups that are working on factors that make folks less and more likely to seek supports, how we bridge some of those gaps. And so I'm really looking forward to some of those outcomes and some of those things kind of growing in the next few years. I do think it's important to also acknowledge some of the things that are currently happening. I know on our campus, Dr. Melinda Smith is doing a fantastic job at leading our EDI portfolio. If you are a UCalgary student or staff member and you have not completed our equity census, please go do that. We are looking to increase our data in this area. And so for us to have the numbers, we need folks to complete it. So I would encourage you to do that. I think it's fantastic that on the 18th of November, the University of Calgary and other schools as well signed onto the Scarborough Charter, which essentially commits to fostering Black flourishing, inclusive excellence, mutuality, and accountability in order to address anti-Black experiences on our campuses all across Canada. It was really exciting to read that the University of Alberta is looking to bring 7 outstanding Black scholars and kind of work them through and make them present in faculties in their programs. And so I thought that was really cool. Also, I think it has been mentioned, the Alberta Black Therapist Network provides ways for folks to connect with therapists that are Black, for folks who are looking for that. But I also recognize that the BIPOC Mental Health Resources YYC team have a page that also lists some of those supports as well. Something that I was really excited to learn about recently, I guess just even an hour ago on Twitter, is that the Canadian Black Nurses Alliance, which is an organization started out of McMaster University, actually has a University of Calgary chapter. So really, they are looking to support Black nurses as they work through both our executive, healthcare, and education spheres, and really bring the strengths of Black nurses to the forefront. And so all of these things that are happening, I think, are really exciting and provide an opportunity for folks to connect, even if it's just reading the Scarborough Charter and seeing what your university is committing to and how you can be a part of that. I think that is a step in the right direction, and to be honest, the kind of allyship that we're looking for. And so I really like this tweet that I saw. I spend a lot of time on Twitter. It's a really exciting place. Black Twitter is a great place if you don't know. But I really like this quote by Makara Jones, and it says, "Could you imagine waking up in your Black body every day and not being burdened by systemic racism? Your health and your safety are prioritized. You are given the benefit of doubt. You are believed. You are valued. You're supported. You're trusted, and you're affirmed by default." And I think while we talk about Black history, I think it's also important to talk about Black future and what that could look like, and to sort of dream and work towards that outcome. Something that I also think is really important is the idea that Black excellence ends in just really tenure or academic papers. I would like to see the idea of Black excellence expand, to be honest, outside of that. And someone that I know does that really well is Destiny Kimura, who completed her Master of Architecture here this past year. And she was actually commissioned by Pink Flamingo to create a Black youth mural. And this is by the Bob Behan Aquatic and Fitness Center. And I love it. And I think it provides really where I would like to end off tonight, in that, you know, I think Black joy is achievable. I think it's attainable, but I know that it requires a community effort. And so I would personally like to, you know, rest as a Black person. I think we've done a lot of work. There've been a lot of things that have been happening over the last 2 years that have really put a lot of work and emotional labor on some of our shoulders. And I would like to see some of the folks that are doing this work really come into really great rest. So with that, I will bring my presentation to an end tonight and welcome any questions.
Thank you so much, Kome, for that amazing presentation. We really appreciate you taking time to speak at our event. And we already have some questions rolling in. So I will just ask to pause the recording